Hello, I'm Shivkumar, the editor-in-chief of JACC Clinical Electrophysiology. It's a rare honor and a privilege for me to interview Professor Marchlinski, actually introduce him as our incoming deputy editor for the journal. And as it turns out that we are discussing a paper by Dr. Chaumont from University of Pennsylvania, a postdoctoral researcher in Dr. Marchlinski's group. The paper is about endocardial ablation of arrhythmogenic RV dysplasia. Frank?
Thank you, Dr. Shivkumar. I'm going to wear my hat today as a deputy editor and try to pass along some new information, I believe, related to the subject at hand, and that is doing catheter ablation from the endocardium only in patients with arrhythmogenic right ventricular cardiomyopathy. We happen to have a large cadre of patients that we've done catheter ablation on in the setting of arrhythmogenic right ventricular cardiomyopathy, and we have the opportunity to share information, especially in the setting of patients with very, very long-term follow-up, if I remember correctly, over 6+ years.
6 years.
In addition, we have the group of patients with primarily endocardial only ablation, and we get to talk about how those patients were selected and the outcome long-term with catheter ablation in this setting. And specifically, I know you spent the time looking at factors that may predict outcome in this patient population. So if you can, enlighten us a little bit about what you found and what the clinical implications might be.
So yeah, we had the chance in Penn Hospital to have a kind of systematic approach in which an extensive endocardial ablation was always performed first, and then the patient was tested for inducibility, and if he was non-inducible at the end of this endocardial ablation, the procedure was stopped at this point and without proceeding systematically with an epi access. And that was a good opportunity. We could study on a very long-term follow-up this subgroup of ARVC patients, and the main finding was that over 50% of the patients were free from any VT recurrence on long-term follow-up, and the success rate even reached 75% in patients in whom non-inducibility was achieved at the end of the endo-only procedure. And then we performed a univariable and multivariable analysis to search for the predictive factors of VT-free survival. And we found, of course, that non-inducibility was a very strong predictive factors of VT-free survival, but also age higher than 45 years at the time of the first arrhythmic events was a good predictor of long-term success after endo-only ablation. So yeah, our data suggests this stepwise approach when non-inducibility can be achieved in ARVC patients.
Yeah, and I think we obviously want to emphasize that we don't do ablation in all patients. So patients with limited substrate, we get access to the epicardium typically on the day of the procedure, primary procedure, and so that, but in selected patients with a significant endocardial substrate, these were the results. And I think the results were important because of not only long-term follow-up, but a reduction in antiarrhythmic drug therapy, which was dramatic. No limited amiodarone, I think in only one patient. Very rarely do we need antiarrhythmic drugs. So there are patients where this works. It needs to be investigated even more completely to see whether there are we can identify procedural aspects. On first blush, we didn't see anything, but whether there's something else we can identify in this group of patients that say they're going to be successful beyond what you found, which was age, an older patient population, more endocardial substrate, and patients who were able to make them non-inducible. Dr. Chaumont, thank you very much.
Thank you so much.